The following audio is part of a certified educational activity titled Advances in Tardive Dyskinesia, a Patient's Journey from Diagnosis to Management and the Role of New Therapies for Improved Outcomes. Access the entire activity and complete the post-test at www.peerview.com/UPT. Downloadable slides and practice aids are also available.
Today, I'll be discussing the identification, assessment, and management of tardive dyskinesia. This disorder is characterized by abnormal, involuntary movements of the tongue, lips, face, trunk, extremities, and sometimes even the respiratory system. It can be severe and persistent and may have both medical and psychological effects. For example, tardive dyskinesia has been associated with poorer quality of life and increased mortality. In general, tardive dyskinesia occurs in individuals with prolonged exposure to dopamine receptor blocking agents, such as patients with bipolar disorder or schizophrenia who receive long-term treatment with antipsychotic medications. In this regard, early data supported the concept that tardive dyskinesia was a manifestation of dopamine D2 receptor upregulation and supersensitivity related to chronic reduction in dopamine availability to dopamine receptors resulting from postsynaptic receptor blockade. An estimated 20 to 50% of patients treated with antipsychotic medications develop tardive dyskinesia. As such, this disorder remains a significant problem for psychiatric patients who may experience stigma, embarrassment, and impairments in social and occupational function as a consequence of developing tardive dyskinesia. Lastly, once established, tardive dyskinesia cannot be reversed in the great majority of cases, making early recognition when it is most subject to treatment and early diagnosis critical for optimal management. Now I would like to share a story with you about a patient. Her name is Janis. She's a 35-year-old African-American woman. She's married, has a 2-year-old child. She also currently works as the general manager of a local restaurant. Janis was diagnosed with bipolar I disorder at the age of 27. Her medical history is otherwise unremarkable. She has a long history of treatment with both mood-stabilizing medications and antipsychotic medications. Initially, Janis underwent a number of treatment trials due to an initial failure to tolerate a number of agents. This included the development of acute extrapyramidal side effects such as dystonic reactions, akathisia, and Parkinsonism from antipsychotic medications. She has also experienced a number of manic relapses, and her most recent episode was just over 3 months ago. During her hospitalization, Janis was switched from olanzapine 30 milligrams daily to aripiprazole 15 milligrams daily in combination with lithium 300 milligrams 3 times a day. Since that exacerbation, she has been in a good remission since discharge, and she continues to see her psychiatrist regularly for follow-up. During her most recent follow-up visit, Janis's psychiatrist was very pleased with her current mood, the regularity of her sleep, her getting along with her family, and her being back to work, and was confident that she remained in remission. A review of her recent blood work, including a lithium level, renal function, and thyroid function, all looked very good. However, Janis told her psychiatrist that a month before this visit, she had developed discomfort in her jaw and noticed over a couple of days smacking of her lips, puckering, chewing, and grimacing movements. These were initially very mild, and she could initially suppress them, but they evolved over a few weeks to becoming more persistent and of greater amplitude. They clearly seemed to be involuntary, and she was not consistently able to suppress them. So let's address the question: has Janis developed tardive dyskinesia? So what are the risk factors for tardive dyskinesia? Certainly, older age is a very powerful risk factor, and individuals over 50 years of age have a much greater risk for developing tardive dyskinesia during continuous treatment with dopamine receptor blocking agents than people in their 20s and 30s. The difference is in the range of 5% a year versus 30% a year. Janis is still a young woman. Another risk factor, though, is the development of acute early extrapyramidal symptoms, such as Janis experienced early in her treatment. Some other factors, including brain injury, infection in the central nervous system, may also make someone more likely or at risk to develop tardive dyskinesia. Alcohol or substance abuse may be a risk factor, perhaps because this leads clinicians to use higher, more aggressive dosing with antipsychotic medications. Let's take a look for a moment at the DSM-5 definition. Involuntary, athetoid, or choreiform movements, generally of the tongue, lower face and jaw, and extremities, but sometimes involving the pharyngeal, diaphragmatic, or trunk muscles, developing in association with the use of neuroleptic medication for at least a few months. Symptoms may develop after a shorter period of medication use in older persons. In some patients, movements of this type may appear after discontinuation or after change or reduction in dosage because we are exposing supersensitive dopamine D2 receptors, in which case the condition is called withdrawal emergent dyskinesia. In a small percentage of people, withdrawal emergent dyskinesias may resolve on their own if antipsychotics can be discontinued, but they're usually just the earliest manifestation of a long-lasting and persistent problem that develops into standard tardive dyskinesia. So let's talk about the differential diagnosis of tardive dyskinesia. We'll sometimes see familial disorders such as Huntington's disease or Wilson's disease or Tourette syndrome. There are other forms of spontaneous dyskinesias, especially in the elderly, and occasional patients with developmental disorders such as autism will show movements that have some slight similarity to tardive dyskinesia. Getting the full history, including a family history, will help us distinguish among these possible choices. The Abnormal Involuntary Movement Scale, or AIMS, is a validated tool for assessing and monitoring tardive dyskinesia severity. The AIMS is a 12-item anchored scale that is administered and scored by the clinician. Items 1 through 10 are rated on a 5-point scale. The first 4 items focus on orofacial movements. Items 5 through 7 deal with extremity and truncal dyskinesias. Item 8 is a global severity item, taking in all movements over the examination. Items 9 and 10 assess the patient's awareness of the movements and the distress associated with these movements. Items 11 and 12, although listed last, are best addressed right at the beginning when we ask patients, do you have anything in your mouth? Are you having any discomfort from your teeth or any problems with your dentures? So we're sure we're not including those kind of movements in our assessments for tardive dyskinesia. Let's talk about scoring the AIMS. The total score of items 1 through 7 has been used in many of the comparative trials for treatments for tardive dyskinesia. Item 8 can be used as an overall severity index. Item 9, incapacitation from the movements, and item 10, awareness of the movements, provide additional information that tell us personal facts about how the patient is experiencing these movements that may be very important in clinical decision making. As I mentioned before, items 11 and 12 provide information that may be useful in determining whether dental or denture problems contribute to some of the jaw and tongue movements. So let's get back to our question. Has Janis developed tardive dyskinesia? The answer is yes. Janis has multiple risk factors for tardive dyskinesia, including prior exposure to antipsychotic medication and having experienced extrapyramidal side effects. She meets the current definition in terms of persistence of her symptoms and signs, and they're not attributable to a change in her treatment regimen over the past 3 months. Recent medical history and recent laboratory work do not suggest alternative diagnoses. After administering the AIMS, Janis's score came to a total of 12. All items related to orofacial movement, as well as item 8, the global severity item, were rated as a 3 by her psychiatrist, and this is consistent with moderate tardive dyskinesia. Janis's psychiatrist discussed the diagnosis with her. She asked if there was anything that could be done to treat it. The orofacial movements had become publicly embarrassing for Janis, both at home and when she would drop her child off at daycare. She noted other people were giving her curious looks, staring. And when she was at work, she noticed some of the customers eyeing her oddly. So what are the general principles for treating tardive dyskinesia? In general, clinicians have 3 viable management options when confronted with drug-induced tardive dyskinesia. The first is discontinuation of the antipsychotic drug. The problem is that that is often not a viable possibility. Illnesses like schizophrenia, bipolar disorder, are chronic, persistent illnesses that require ongoing long-term treatment. Second option is to switch to a less potent dopamine antagonist. And the third is the use of adjunctive agents, agents that may relieve the presence of tardive dyskinesia while allowing continuation of the use of antipsychotic medication. Janis discussed these options for treatment of her tardive dyskinesia with her psychiatrist. Based on her recent manic relapse, and that her current regimen has enabled her to be euthymic in good remission for several months, Janis and her psychiatrist felt discontinuing her antipsychotic medication or even switching her antipsychotic medication were not good options. So the most logical approach, based on Janis's history, recent medical evaluation, was to try adjunctive agents. So let's review some of the evidence for treatment of tardive dyskinesia. The data for success in reducing tardive dyskinesia by withdrawing causative agents like antipsychotic medications, switching from typical to atypical antipsychotic medication, is not very convincing. A large number of other agents have been tried, including vitamin B6, selegiline, botulinum toxin type A, and even very aggressive treatments such as electroconvulsive treatment or palatal deep brain stimulation. These have occasionally shown flickers of effectiveness in some trials, but have not been consistently used or shown to be effective. Moving to another antipsychotic agent is simply not a reasonable option in most cases. Clonazepam, a benzodiazepine, may slightly improve tardive dyskinesia, but is associated with the issues of sedation and potential for addiction that long-term use of any benzodiazepine is associated with. Studies for ginkgo biloba have not been consistent in showing release of tardive dyskinesia. Tetrabenazine has been tried on an ad hoc basis, although it's not been approved as an agent for the use in tardive dyskinesia. Tetrabenazine is a vesicular monoamine transporter 2, or VMAT2 inhibitor that modulates synaptic dopamine. Previous studies, mostly case series, have suggested potential efficacy in the treatment of tardive dyskinesia. However, tetrabenazine is rapidly and extensively converted in the liver to alpha and beta active metabolites. These active metabolites have short half-lives that necessitate frequent dosing and that result in large plasma fluctuations that are thought to contribute to the poor tolerability that is often observed with this agent. In addition, tetrabenazine-associated neuropsych adverse events have included somnolence, depression, insomnia, akathisia, and Parkinsonism, and they've significantly limited the use of this agent. Let's talk about a newer agent, Deutetrabenazine. The limitations of tetrabenazine and other off-label treatments led to research into potential treatment alternatives for tardive dyskinesia. Deutetrabenazine is a novel and highly selective VMAT2 inhibitor that contains deuterium, a naturally occurring non-toxic form of hydrogen. The incorporation of deuterium attenuates metabolism, leading to decreased plasma fluctuations compared with conventional tetrabenazine, and reduces the adverse events associated with peak concentration. For example, deutetrabenazine significantly decreased chorea, improved overall motor function, and was well tolerated with low rates of neuropsychiatric symptoms in patients with Huntington's disease. We'll go over the trials of deutetrabenazine for patients with tardive dyskinesia. The ARM-TD study was a 12-week randomized, double-blind, parallel group study of 117 patients with moderate to severe tardive dyskinesia. Patients were randomized 1-to-1 to receive deutetrabenazine or matching placebo. After randomization, study drug was started at 12 milligrams daily, that's 6 milligrams twice daily, and titrated weekly by 6 milligrams a day, if required, for up to 6 weeks until adequate dyskinesia control was achieved, until an unacceptable adverse event occurred, or until they reached the maximum allowable dose of 48 milligrams daily. This was followed by maintenance for 6 weeks and a 1-week washout. The primary endpoint of the ARM-TD study was the change in Ames score from baseline to week 12. Secondary endpoints included treatment success at week 12 on the Clinical Global Impressions of Change, the CGIC, and a Patient Global Impression of Change. For the primary endpoint, deutetrabenazine significantly reduced Ames scores from baseline to week 12 relative to placebo. Treatment success on the CGIC favored deutetrabenazine, but did not achieve statistical significance. Deutetrabenazine and placebo groups showed low rates of psychiatric adverse events such as anxiety, depressed mood, or suicidal ideation. The AIM-TD study was another phase 3 trial of deutetrabenazine for the treatment of tardive dyskinesia. In this trial, 298 patients with tardive dyskinesia received one of the following: placebo, deutetrabenazine 12 milligrams daily, 24 milligrams daily, or 36 milligrams daily. 222 patients comprised the modified intention to treat population. 293 patients comprised the safety population. The primary efficacy endpoint was change in Ames score from baseline to week 12 in patients with at least one post-randomization Ames rating. From baseline to week 12, the least square mean Ames score improved by 3.3 points in the deutetrabenazine 36 milligram daily group, by 3.2 points in the 24 milligram daily group, and by 2.1 points in the 12 milligram daily group relative to a 1.4 point improvement in the placebo group. The rate of adverse events was similar between patients in the Deutetrabenazine 36 milligram per day group, 24 milligram per day group, and 12 milligram per day group, and those in the placebo group. 2 patients in the safety population died, 1 each in the Deutetrabenazine 24 milligram per day group and 36 milligram per day group. Neither death was deemed related to study drug. Based on the results of this study and the ARM-TD trial, Deutetrabenazine was approved for the treatment of tardive dyskinesia in 2017. Valbenazine is another agent recently approved for the treatment of tardive dyskinesia. Valbenazine is also a VMAT2 inhibitor. It is metabolized to plus alpha dihydrotetrabenazine slowly, and thereby minimizes high peak plasma concentrations, decreases peak to trough ratios, and reduces intersubject variability in pharmacokinetics of its active moieties. KINECT-3 was a 6-week randomized, double-blind, placebo-controlled trial conducted in patients with schizophrenia, schizoaffective disorder, or a mood disorder who had moderate or severe tardive dyskinesia. Participants were randomly assigned in a 1:1:1 ratio to once daily placebo, Valbenazine 40 milligrams daily, Valbenazine 80 milligrams daily. The primary efficacy endpoint, again, was change from baseline to week 6 in the 80 milligram per day group compared with the placebo group on the total of items 1 through 7 of the aims. Let's look at the results of KINECT-3. In the intent to treat population, including 225 participants, 205 completed the trial. The least square mean change from baseline to week 6 in the AIMS dyskinesia score was a 3.2 drop for the 80 milligram per day group compared with a 0.1 drop for the placebo group, a significant difference. The AIMS dyskinesia score was also reduced in the 40 milligram per day group, a reduction of 1.9 points compared with a reduction of 0.1 point in the placebo group. The most common treatment emergent adverse events for Valbenazine were somnolence, akathisia, and dry mouth, while suicidal ideation was the most common in the placebo group. Based on the results of this study, Valbenazine was approved for the treatment of tardive dyskinesia in 2017. So let's talk about treatment selection for our patient, Janis. After a lengthy discussion about available therapies, both approved and off-label, and shared decision-making between Janis and her psychiatrist, a decision was made to start Deutetrabenazine and add it to her current treatment regimen. The initial dose was 12 milligrams daily, administered as 6 milligrams twice a day. This was titrated weekly, upward by 6 milligrams a day until she achieved a dose of 30 milligrams a day, at which point a very substantial, readily apparent reduction in her tardive dyskinesia severity had been noted. Her AIMS score was reduced by approximately 60% from baseline, which proved to have important improvements in her life, in her comfort in being out with other people, and less evidence that others noticed any movements. Janis continues to be monitored regularly for the reemergence of manic symptoms, as well as for worsening of current or development of new tardive dyskinesia symptoms. Janis's story highlights a number of points related to tardive dyskinesia. The first point being that tardive dyskinesia is a relatively common occurrence in patients receiving long-term treatment with antipsychotic medication. In addition, patients taking antipsychotic medication must be monitored on a regular basis using an established instrument such as the Abnormal Involuntary Movement Scale in order to immediately detect and promptly treat tardive dyskinesia should it occur. 2 new VMAT2 inhibitors have been developed and are now available. These agents retain the efficacy of tetrabenazine, but offer substantially improved tolerability. These agents, Valbenazine and Deutetrabenazine, were recently FDA approved for the treatment of tardive dyskinesia and provide much needed treatment options to alleviate these abnormal involuntary movements. Thank you for your attention, for joining us today.
This activity has been jointly provided by the University of Cincinnati and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/UPT. This activity is supported by an educational grant from Teva Pharmaceutical.